For this next session, I would like to call upon stage our next panel of chairpersons, Dr. Shikha Gurnani, Dr. Anita Rajoria, Dr. Ritu Jain, and Dr. Puneet Kochar.
First of all, thank you to all the organizers for involving gynecologists in such huge numbers. All the cases are very interesting, and they are keeping us on the edge so that we can discuss them and take advantage of being in close proximity with endocrinologists today. So now the next session, we have 3 interesting cases. The first case will be discussed by Dr. Chitra Selvan. She'll be discussing a case of a 29-year-old lady with Graves' disease on carbimazole, 20 milligrams per day. Now she's planning to conceive. So how we are going to proceed further? Welcome, doctor.
A very good afternoon to the chairpersons. I will be sharing this session with Dr. Belinda George, who's going to be with me as well. Can I request for a handheld mic, please?
Welcome, Dr. Belinda. Welcome to the dais.
Thank you, ma'am.
A very good afternoon. Thank you, chairpersons, for that kind introduction. Thank you, Speed, for having us here. And it's extremely great to see a hall which is full on a Sunday afternoon. We've been given a very specific task. We've been asked to discuss the management of a 29-year-old lady with Graves' disease who's on carbimazole 20 milligrams per day, who's planning to conceive. So we'll begin with case scenarios, and we will be taking all the inputs from the audience and then maybe discuss it. So this is not a talk, it's going to be more discussion. So we begin with scenario 1, and I'm going to ask the audience, okay? So in the first scenario, this is a newly diagnosed individual who's been on anti-thyroid medications for about 3 months, and she's come back for her first follow-up with us. Her TSH is suppressed, as would be expected, right? Her T4 and T3 are in the normal range, right? She has a small goiter. She has no ophthalmopathy. In the last 2 months, she's gained about 4 kgs of weight, which is very common and expected when you start individuals with thyrotoxicosis on anti-thyroid drug, right? She's gained about 4 kilos of weight. And now she's thinking of planning a pregnancy, and she wants to start a conversation with you, right? So what should we tell her? Should we tell her wait, or should we tell her don't plan till TSH normalizes, or should we tell her something else? What should we tell? What does the audience say? Plan for pregnancy. Immediately? Immediately? After stopping? After stopping. Anybody else?
What kind of ATD she is receiving?
Ma'am, she's on carbimazole. That has been decided by Dr. Sameer and team. She's on carbimazole 20 milligrams now.
We have to stop it.
3 months.
3 months.
Yes. Wait for pregnancy.
No.
Wait to conceive. Meaning?
Defer pregnancy.
Defer pregnancy. Okay. Okay. Dr. Belinda, you want to give us your inputs?
All right. So this is a scenario where there's a lady who is on currently 20 milligrams of carbimazole and is looking like she's responding well to the therapy of choice that you have given, because she's gaining weight. You can see that her T3 and T4 has normalized. The only point is that TSH has still not come up. But that's not odd at all, because TSH will take time to come up. And so it's not a worrisome feature at all when we see that the TSH is not normalized. There is no reason for you to increase the dose. This is the expected response. So what should be our action here? She's responding well to therapy. So she is doing well. So ideally what we should do is we should encourage her to continue the same form of therapy, because the ATD response is good. However, 20 milligrams of carbimazole is probably not the ideal dose one should consider conception. In an ideal scenario, what you should do is you go ahead, Generally we give therapy for Graves' disease to the tune of 1.5 to 2 months, at least 2 years, sorry. So at least 18 months of therapy is advised in patients with Graves' disease. So what you should do is you should counsel her and tell her that ideally this is not the time to conceive. If possible, wait for the entire course of ATT to be completed. You go off therapy, you stay in remission, and then you conceive. That would be the ideal thing to do. However, if the patient says, no, I'm not willing to wait for another 1 year, I want to conceive as soon as possible, then it is all right for you to say, or at least that option can be given to the patient, don't conceive when you're on 20 milligrams of carbimazole, wait till you come down to, let's say, 10 or 5 milligrams, and that's a safer range where you can take off the medication when the patient becomes pregnant. So that would be a better solution, though not ideal. So the exact advice here would be, please defer pregnancy if possible for the next 1 to 1.5 years. If not, at least defer it until we feel that you are euthyroid on a minimal dose of carbimazole.
Sir
And when we
wants to
define,
make a point. Sir wants to make a point.
Sure,
Please
sir.
give him a mic.
You are considering a patient who's come to you before she got pregnant.
before
Usually-
conception, sir.
Before conception. So this would be ideal to reinforce the regime that all these patients, you should first make them have a definitive therapy and then get them pregnant.
Yes, that should be the ideal.
Yes,
Yes,
all right.
so ideally, we would like to, the only point to add is that how will you define euthyroidism? So the patient should have the stable dose or the same dose of carbimazole 2 visits apart, which is roughly 4 to 6 weeks apart, with normal T4, T3 values. That should be your target before you allow the patient to conceive.
Perfect. So,
So
but
shall I go on to another scenario,
yes, please.
if there are no other comments? So we are,
1 second.
Patient is planning for pregnancy and she is on neomercazole or thing, and if she is getting pregnant, so should we shift her to propyl therapy?
Yes, sir. 100%. We will.
Yeah.
She
We
will
will
get pregnant
come to
soon.
that.
Yeah,
Yeah.
we'll come to that.
But pre-pregnancy only
So-
will,
Or before conception.
before conception.
shall we go to the
we-
next?
Yes, please.
Shall we go to the next scenario, ma'am?
Maybe
Will
we'll
you
answer.
consider changing over to PTO? People want to know. Yeah.
We will.
We will answer
not,
that later.
Yes, sir.
We will come to that, sir.
Yeah.
Dr. Belinda, I think we'll proceed with the slides and address the questions in the end
Sure.
because you'll be covering a lot of questions in your slides.
Sure. Yes,
Yeah.
we'll cover that, sir.
Point.
So we'll go to the next scenario. Here again, the patient is on 20 milligrams of carbimazole, but the difference here is that now the patient has been on this therapy for more than 18 months. In spite of that, you can see that the T4, T3 is slightly elevated and the TSH is still suppressed. So here, can we have comments from the audience is how your approach would be different in this scenario as compared to the first scenario? Yes, ma'am.
Radioactive
Excellent.
ablation
Any
is a
other
choice.
comments?
So this patient is refractory to the therapy.
Sir?
This patient is refractory to the medical therapy.
Yes,
so
sir.
we should move towards the
Definitive therapy. Okay. So
Excellent.
unanimously, we all agree that we probably need to now think of definitive therapy. Next slide. So the
Yes.
options which are available for us are radioablation and surgery. So there are certain nuances that we must consider before we choose either of these two. Radioablation, of course, we know is contraindicated during pregnancy and also maybe 6 months preconception. Now, where did that number 6 months come from? It's an estimate, right? So we think that at least 6 months should be enough to rid the body of all the, changes which happen after radioablation. So up to 6 months of time should be, and the patient should understand that clearly, right? And wait for 6 months and use contraception. Also, that is the 6-month window which you use to treat and normalize the hypothyroidism which results after radioablation, and they remain euthyroid for at least 6 to 8 weeks before we give them the green signal to go ahead and plan pregnancy. Some points about radioablation that we must remember: if they have ophthalmopathy which is active or moderate to severe, please remember there's a small possibility that the ophthalmopathy can worsen. So that would probably make you choose surgery over radioablation. The third point is there can be a transient rise in TSH receptor antibodies after ablation. Now, if conceiving very quickly is of importance to your patient. If you radioablate now, the antibodies might rise and they might not settle down for up to 9 months to a year after ablation. So there's a small chance that you might increase the probability of fetal hyperthyroidism in the child. These are all the points that we must discuss so that we can choose. Of course, surgery gives the advantage of maybe a shorter wait period to do the surgery, and then within a week you start levothyroxine. Maybe in about 2-3 months she can be ready for conception. But of course it's an invasive procedure, comes with a certain risk of complication even at the hands of the best thyroid surgeons. Of course there's a scar which is very important to all of us, that we want no scars in visible areas at least. But the advantage could potentially be that there could be a drop in the antibody level even up to 80% after a surgery versus radioablation. So those are all the options or the points that you might need to consider while you're choosing radioablation or surgery. Does anybody in the audience have any comments or inputs?
If I can just add one statement to this scenario, the only thing that you have to emphasize here is that this patient has uncontrolled hyperthyroidism. So here you should strongly advise against pregnancy, because uncontrolled hyperthyroidism definitely is associated with a lot of consequences like miscarriages and pregnancy complications and even fetal complications. So this is a scenario where you would actively tell them, please do not conceive, use contraception and defer your pregnancy.
No comments? I think this section we are all very clear. All right, perfect, thank you. So maybe now I'll ask Dr. Belinda. So we go back to the initial scenario, right? Who's a newly diagnosed person with Graves, who's been on antithyroid drugs, 20 milligrams for about 3 months. She comes for the next follow-up. Her free T4 and free T3 are in normal range, but TSH is still suppressed. Now she's had amenorrhea for 5 weeks and her urine pregnancy test is positive. We did tell her, but it's positive now. So what should we do next? Should we think of terminating pregnancy? Should we recommend that? Should we continue carbimazole same dose? Should we now switch the antithyroid medication, or should we think of surgery? Inputs from the house? Switch to PTU. Everybody's agreeing. So is terminate pregnancy an absolute no? Everybody's agreeing? Okay, perfect. Belinda, you want to take it?
Yes, sure. So I think all of us agree with regards to the strategy here. And why do we need to switch the medication from carbimazole to PTU? Mainly it's because of teratogenicity. So both drugs are actually associated with some small degree of teratogenicity. However, the defects that you see with PTU are mild issues. So you can easily fix them even if there are small issues. The ones that, even though it's rare, the side effects seen with carbimazole are quite significant. Like you must have heard of aplasia cutis, which is predominantly a cosmetic issue, but that's something that is very specifically associated with carbimazole. But the other things that we can see are choanal atrasias, which can be quite a significant anomaly at birth, or abdominal wall defects like omphalocele. So they are major congenital anomalies, which is the reason why we always prefer to use PTU over carbimazole. We also had the discussion prior to this as to, why don't you switch to PTU when the patient is trying to conceive rather than wait, and then once the patient conceives, then why do you shift to PTU? The only reason why PTU is not preferred as opposed to carbimazole is because of its risk of hepatotoxicity. Now the problem with the hepatotoxicity associated with PTU is that it is an idiosyncratic reaction. So there's no way you can predict this particular, or you cannot monitor the LFT and say, okay, LFTs are normal now, there is no enzyme elevation, so this patient is going to be safe to use in this patient. We have no way of predicting who is going to develop PTU related hepatotoxicity, and once they develop, it is a necrotizing hepatitis. So it's going to be a downhill course from there, and it is an indication for liver transplantation. So it's going to be an irreversible fulminant hepatitis. This is the reason why we do not use PTU, and the only indication for PTU with regards to treatment in hyperthyroidism is in the small window, which is first trimester of pregnancy, where it has a clear advantage over carbimazole because of lesser risk of teratogenicity. Anything else?
Yeah, thank you. Thanks, Dr. Belinda, for clarifying that beautifully. So to answer your question, sir, so there is no question of switching to PTU the minute the woman is thinking of planning a pregnancy. We only switch it right after the urine pregnancy test is positive, and keep it on for the shortest window. We are waiting for 12 weeks to turn so that we can switch back to carbimazole. I hope that's clarified.
I'd like you to comment on equivalent doses of PTU and
Yes, ma'am, we are coming,
carbimazole
ma'am, we are
for the
coming.
benefit
Sure,
of
ma'am,
audience.
sure. Yes, so the next step is how do we do this switch? I think we have given you the equivalent dose. It's 10 milligrams of carbimazole is equivalent to 200. Since our patient was on 20 milligrams of carbimazole, that is equivalent to 200 milligrams of PTU. So now maybe I can just ask, in the interest of time, I'm going to just ask Dr. Chitra to tell how to switch to PTU and what are the
Yes. So
targets.
since, if you recall, her free T4 and free T3 levels were within normal range. So if she were not pregnant, we would have actually reduced the carbimazole dose at this visit, right? So we're probably not going to send her home on carbimazole 20 milligram and equivalent, maybe reduce the dose to maybe 15 milligram. So if you're going to convert that roughly into 10, we'll give you the PTU dose. So you're probably going to switch to PTU 150 milligrams instead of 200 milligrams. Of course, I think this audience knows clearly that during pregnancy, you're always trying to keep free T4 levels not in the normal range, but towards the upper end of what is normal. So pregnancy tolerates hyperthyroidism slightly better. We never want to overcorrect or overtreat hyperthyroidism, especially during pregnancy. So reduce the dose and then ask her to come back in 4 to 6 weeks time with free T4 and free T3. Should you tighter up the PTU dose based on the TSH value? I think this needs reiteration. We do not titrate the antithyroid medication dose at all based on TSH. TSH can remain suppressed for long periods of time, even in non-pregnant individuals, sometimes 9 months, sometimes a year or more. What about total T4? Does anybody in the audience want to comment about total T4 levels during pregnancy? Beautiful, thank you so much. So the answer from the audience member was that the total T4 levels rise up by about 50% during pregnancy. That is attributable to the fact that the estrogen levels which rise during pregnancy cause an increase in the sialization of the thyroid binding globulin, because of which the clearance is slowed down. So the total hormone level actually increase. So this is something that you should keep in mind. This patient lives in a metro city, so we have the liberty of having a lab which can give a reasonably reliable free T4, free T3 values. But if you do not have access to a lab which can look at free T4, free T3, you can very well follow up with total T4 and total T3. Just remember that levels are elevated during pregnancy and adjust for it accordingly, right? Is there anything else that anybody would like to discuss or share
I'll just add one point with regards to the free hormone assays. When you talk about pregnancy, you also should have trimester specific and assay specific free hormone reference ranges. So that's something that you should keep in mind, because between assays also there'll be some difference in the free hormone ranges. So yes, keep it in the upper limit of normal, but also ensure that it is assay specific and trimester specific. So if you do not have access to a robust FT4 and FT3 assays, please feel free to use total T4 and T3. Only remember it has to be calculated to 1.5 times the normal. Yeah.
Okay, so I'll ask you this. So she's now at 13 weeks of gestation. We have managed to meet her one more time and reduce the PTU dose from 150 milligrams to 100 milligrams, making sure that the free T4, free T3 levels are towards the upper end of normal. So currently she's on PTU 100 milligrams per day. Right now her total T4 value is 14.5 microgram per deciliter. Please remember, this lab report, when it comes printed from the lab, will be in bold, and the patient will be in panic when she walks into the room, right? Because they don't give a pregnancy specific total T4 values, and the TSH continues to be 0.05. What should we do next? What should we do? Should we reduce the dose of PTU, continue the same dose of PTU? Change to carbimazole, brilliant. So we want to keep them on PTU for the shortest window of time. Very good, we've all understood that. So we want to switch back to neomercazole. Do you want to tell me what dose of neomercazole? Should she be on 10 or should she be on a slightly lesser dose? But total T4 is 14.5, ma'am.
It's well within your target. Your target is 18. Up to 18 can be,
Okay.
it's normal. Up to 18.
Okay, yeah.
So, yes, you want to say?
I'll add a point. So the management of Graves' disease becomes easier in the second trimester and the third trimester, meaning the requirement of antithyroid drugs drop down even naturally in the second trimester and the third trimester, because autoimmune conditions, all of them flare up in the first trimester and settle down in the second and settle down further in the third. So we are always trying to maintain thyroid hormone levels at the upper limit. So anticipating that and the fact that total T4 is well within range here, I would maybe reduce the dose and maybe send her on 7.5 milligram. Dr. Belinda, would you agree?
Yes, I agree with that too, because even in pregnancy, like we mentioned earlier, your target is not to raise the TSH. Your target is to maintain euthyroidism at the lowest possible ATD dose. So we should always attempt to down titrate the dose, provided T4 is or FT4 is well within the normal range. So I would also cut down the dose to 7.5.
Is there anything else we should do at this visit? She's 13 weeks gestation. Should we look for anything else now? Should we? Anomaly scan.
With related to thyroid and Graves.
No, we'll get there, I think. Sorry? All
Yes,
that is your
very
department.
good, very good. Yes,
Trab.
excellent. So
Okay.
her TSH receptor antibody level was elevated
It was
at 8.
8. What is the relevance of doing this antibody level? Fetal? So the antibodies which can activate the TSH receptor, if positive in the mother, can cross to the placenta and reach the baby, and it can cause fetal hyperthyroidism and also might predict the chances of neonatal hyperthyroidism. So at around 13 weeks to 20 weeks, before we probably do the anomaly scan, it makes sense to do the antibodies. If it is negative at this point, you can relax. There's no need. If it's negative at this window, it's not likely to become positive later on. But if it is positive, it is important to follow up, not just the antibody levels, but maybe also monitor the child. So what should we monitor in the fetus for hyperthyroidism if the antibodies are positive? Fetal goiter, very good, ma'am. Anything else?
We can estimate thyroid level even in amniotic fluid, they say.
But that's an invasive procedure, no, ma'am. We're scared of invasive procedures.
Fetal thyroid on ultrasound, we can monitor. Yeah.
Fetal
Monitor for
goiter. Fetal goiter, ma'am said. Can we check fetal heart rate?
Somebody said.
Growth and amniotic fluid index, right? So, next slide, Belinda.
Why
Yeah.
you
it's
say
here,
that
it's here.
TRAB should be done at 13 weeks? Can't we do it earlier?
You can do it earlier,
We
ma'am.
can do
You
it
can
earlier,
at the
ma'am.
first
We can do it
visit.
earlier. Yes. So,
Please.
मैंने तो लिखा ही था सबसे पहले before
Trap should be done if you do it at 13 weeks. You have to repeat it at 20 because it's well known that at about 20 weeks, the permeability of the trap increases, and then that goes to the fetus more. So 20 weeks is the ideal time.
What sir was saying is ideally. What I can repeat what sir said. So the recommendation for TSH receptor antibody testing is ideally at the first antenatal visit. Second test to be done at 20 weeks of gestation. If the first one is positive, you don't have to repeat it after that. But if the first one is negative, you don't have to repeat it after that. But if the first one is positive, you repeat again at 20 weeks of gestation. If that's also positive, you can again repeat it at 32 weeks of gestation. So that's the recommendation. It is essentially to look at risk of fetal thyrotoxicosis. So the 20-week titer correlates much better with fetal thyrotoxicosis rather than the 11 or early first trimester of the first visit TSH receptor antibody. No, ma'am. Even if there is fetal, the idea of doing TSH receptor antibody is not to decide the fate of the pregnancy. It's only to screen for fetal thyrotoxicosis. Even in women with high titers, it's not necessary that the fetals will have thyrotoxicosis, but there is a possibility that they could have. So if it happens, we should intervene and treat, and that is also possible. Which So.
next slide, Belinda. Okay.
So slightly off track, if we can just take it away from the lady who was the scenario given to us. Here is a patient who currently you are seeing for 18 weeks of gestation, and has history of Graves' disease, has been ablated 5 years ago and currently is hypothyroid post-ablation on L-thyroxine therapy. So in this patient, is there anything else very similar to the discussion that we are having that, yes.
Trab again. I think this is something that we all very easily forget. I think when we realize that you're on levothyroxine, we sometimes might not ask, did you ever have Graves' disease before? Were you radioablated previously? Or even whether you had a surgery, what was the etiology for the surgery? Was it Graves' disease? Because the antibodies can be present in the mother for years after surgery, but probably for longer years, or the chances of having antibodies are greater if they were radioablated. So I think this is something that we must keep in mind, and maybe that's a point of practice that we can take back home. So, and if the antibodies are positive, we follow the same protocol as we would, as we discussed previously. Next slide, please. So we'll come to, now we've managed her Graves' disease extremely well. What happened through the course was that we reduced the neomercazole dose. We switched back to 7.5 milligrams. Gradually, we were able to reduce it. And as expected, the requirement came down. And by about 28 weeks of gestation, we were able to take her off carbimazole. But we still continued to monitor her, and she was euthyroid throughout.
You can
Okay.
for us.
Yeah, we'll finish soon. Yeah. She was euthyroid throughout pregnancy, and she delivered a healthy child. What should we do now? What should be the plan? Everything is perfect. Do we send her home to her mother's house, or? Baby's TSH, yes, very correct. Baby, we are checking for neonatal hyperthyroidism. Very, very good point. Anything else?
Mother?
Should we do now? Why are we doing mother's antibody again?
Thyroid function has to be monitored.
Yes. When should we do the first TSH T4 in the mother? 6 weeks, perfect, yes. Should we repeat again? 3 months, yes. Why are we doing the TSH? After delivery, you can have a flare-up of all autoimmune conditions. So we can anticipate, we should anticipate a recurrence of Graves' disease. So 4 to 6 weeks, and then again, like ma'am said, 3 months. Should we do it one more time? 6 months is also recommended, right? So it's important that we continue our surveillance for recurrence postpartum as well.
And good contraception has to be advised.
Sorry, somebody said that.
Contraception.
So, shall we? Okay, so these are our takeaway points. First of all, let me thank the audience for being such a lively audience, and we had a wonderful interaction with you all. So these are our concluding points. Uncontrolled Graves' disease, like we said, has adverse pregnancy outcomes, so you should actively discourage the patient from getting pregnant if the patient is having active hyperthyroidism. In the first trimester, the drug of choice is propylthiouracil, but however, as soon as they complete the first trimester, switch them back to carbimazole because that has lesser side effects for the mother. The target range of FT4 is upper limit of normal. If you do not have FT4 assays, you can use total T4, and it should be 1.5, the upper limit of normal. That is in the non-pregnancy range. And never ever target TSH when you're treating hyperthyroidism in pregnancy. If you get a normal TSH, understand that you're over-treating the mother. You have to cut down the dose of the antithyroid agent. The importance of thyroid receptor antibody we discussed at length, and of course fetal, neonatal and postpartum monitoring of the mother should not be forgotten. Thank you very
so
much.
Thank you.
And this
Thank you, Dr. Belinda and Dr. Chitra, for enriching us. Now we feel more empowered in managing our obstetric patients.
Thank you for the kind words, ma'am.
Thank you for those nice carry-home messages.
Just a comment, Doctor, it was an excellent discussion. In markers for ultrasound, it is the fetal goiter which we consider the most specific, because the other parameters can be altered due to other reasons also, PIH and other.
Noted, ma'am. Heart rate and fetal goiter are specific. Yeah. Thank
Will
you.
you give a last comment on any role of steroids if TRAP comes positive?
not at all, ma'am.
Not
No
at
role
all.
of steroids at
steroids,
all.
ma'am. Thank you so much.
Thank you. Thank you, everyone.